CRP is rising, TLC is high, patient is very irritable and they refer to TFC. First thing we do is do the echo and it shows actually aneurysm. So maybe we are missing in the pedigree and early IVIT is not given, that's why we are getting more coronary. So if we are more able to sensitize the pediatricians with the conferences like that, maybe our coronary, the cardiac incidence may reduce.
Definitely, that must be one of the reasons. So, KD awareness and belief in KD that still are lacking in majority of the population. But that may not again be because we have seen patients also with diagnosed day 5, day 6, day 7 with big aneurysms. So that has also been observed.
So how long does it take? So for after fever, how long does it normally take for the cardiac system to be fixed?
Usually, if you go by the literature, around 10 days. In fact, Dr. Sudha also showed some slides yesterday that the aneurysm starts forming around 10 days.
No, the dilatation.
Dilatation can be before that.
Usually first 7 days there are no changes. First 7 days there may be no coronary changes. So it is incorrect to say that this is not KD because coronaries are normal. And that is a mistake which occurs time and time again. Dr. Saji, what has been the experience in Kerala? Kerala is one state where KD is diagnosed very early. And I think we need to learn from the experience of Kerala because there, even small hospitals, even in the government setup, small district hospitals, they are all primed up for KD. So, what has been your experience over the last 30 years as far as the incidence of coronary complications is concerned?
Yeah, the recent the incidents are not much higher, especially the coronary artery involvement. And even the myocardial infarction also, we are not seeing at all in the because they are taking care of with anticoagulant, antiplatelet and all regularly. And all the pediatricians in the village setup itself, they are well aware and the awareness towards any rashes, they think about KD and they will call us, and so the awareness has increased in Kerala. So that early treatment may be the another reason. The coronary means the aneurysm changes or giant aneurysm cases are much less actually. That's why yesterday I couldn't give the answer to the surgical point of view because nowadays we are not sent any case for bypass so far.
I remember Dr. Cassidy. Dr. Cassidy, when he had come here in 2001, so he said that previously he used to say that when you suspect KD, you treat KD. He said now we teach our fellows, when you think of KD, you treat KD. So the dilemma whether this is KD or not, that dilemma can continue at the bedside. But once the possibility of KD arises and you think there is some reasonable chance that this can be KD, one should immediately treat, even though the final diagnosis may not be KD. But you can't take the risk. So if you delay the treatment over 4 or 5 days, that is all it takes to damage the coronaries, and that damage can be irreversible. Sir.
Australia, there is no price. The population stratification there, and South Korea, Taiwan, Singapore, and Hong Kong, there is price. And the migration of people, every 4 people person in Australia is migrated. And migration takes place from that area. But they are not increasing. There is no increase in the percentage of cases in Australia. When the student I am asking, is there any relation with the local environment or in political life? This if you look at the population stratification of the Australia, every fourth person is
From
migrated
from the Eastern Asia.
from this part of the, and this part of the globe. But their incidence is not going up.
I think what he said, if I read the slides correctly, what he said was they don't know.
There was
Because their last study
There
was,
is no change in the percentage.
but their last study was several years ago. They don't know. In Japan, Korea and Taiwan, they have, I think these are the only three countries where they have updated data, especially Japan.
That may be a point. I don't know. That is my question.
Because US, Japan, they update their data very regularly and we have very reliable data. In other countries, they may not have
They
updated.
have a very good statement. Those statements are very good. Expected there, I'm not sure whether they are updating their data or not. But their population stratification is like.
Dr. Amitabh?
Sir, you are absolutely right, sir, that the treatment should be started as soon as possible. One of the main hindrances, which is very practical, suppose one of the main ingredients is IVIG. So as soon as diagnosed, we give IVIG and sooner the better so that it at least prevents the formation of the coronary artery aneurysms. One of the main things is the cost. In the government sector, it is free. And in our state also, in the government sector, it is absolutely free, but it is very difficult to get a seat in the government sector for that particular period, for that particular time. If so, then the patient or the child and the family has to take help of some either semi-private or private ones. But the cost is still out of bounds for most of the people, if not the majority, most of the people, they still find it slightly difficult to pay for that one. Nowadays, the cost has come down quite significantly, but in some sectors, the cost is still prohibitive. So that is one of the reasons that people think twice or maybe thrice before subjecting the patient to that one. That is one of the main reasons, I think. But apart from that, as you said, the awareness and the mentality of the pediatricians to act very quickly have gone up significantly over the past 10 years. And they act very, very quickly, if not within the first 2 or 3 days. Even if the echo is not available or the echo is negative, on the clinical grounds as well, I think they want to give the medications as soon as possible. I think you are also noticing several sectors across our state, the mentality here and the perspective has changed quite a bit as of now.
Dr. Devadat.
The pediatricians are now quite well aware, and they are doing the echoes, asking for the echoes, and then they are treating the babies. But once the echo within 7 days, I find them asking for echoes at 3, 4, 5 days also. But once the echoes are normal, we need to stress on the fact that they might, if they are suspecting KD, they will need a repeat echo, even if their initial echo is normal. So there is a false sense of satisfaction that yes, the coronary involvement is not there before then the echoes are done around 6-7 days or so. So I think that needs to be more emphasized.
You know, I would emphasize the fact that for diagnosis of KD, we do not need an echo. Echo can give you some subtle features in the first 7 days, like brightness of coronaries, like loss of tapering of coronaries. That is all that echo will, but to get a pediatric cardiologist to do the echo, in most parts of our country, can take you several days. And that report may or may not be reliable, because the concerned cardiologist may not have enough experience. Very few cities in our country have enough pediatric cardiologists. Most places, it is a cardiologist who does it. And adult cardiologists, unfortunately, do not have the wherewithal to give you a reliable. Echoes quite frequently delay the diagnosis. So only yesterday, one patient that Dr. Suda saw, this was a doctor's child. A doctor's child admitted in one of the most prestigious hospitals of our country. And the child had fever, several courses of antibiotics, admitted, they suspected KD, ruled out KD because echo was normal. they have told the mother, this is not KD because echo is normal. And by the time the diagnosis of KD was made, the baby had aneurysms. So echo is, yes, it's very important to follow up, it is very important to assess KD, but diagnosis of KD, just like diagnosis of acute rheumatic fever, does not need a cardiologist. If you have a cardiologist, yes, by all means involve him. But if you do not have a cardiologist, it should not stop you from diagnosing KD. Dr. Puneet.
Yeah, absolutely right. Only thing is that it is because of the treatment. In acute rheumatic fever, we have been treating like when I was doing PGs, it was the commonest cause of acquired heart disease, which we don't see now. The treatment was penicillin, which is the cheapest drug available. Problem with KD is again because of immunoglobulin. I am in a private hospital, although it is charitable, but the cost comes to around 30,000-40,000. And that is why once echo is normal, then we feel okay, we are giving IVIG primarily to prevent the heart disease, it is not involved, so we can able, and if there is coronaries are involved, parents are very easily convinced that IVIG is indicated, they are totally convinced, otherwise they think doctors must be getting something from this very expensive injection. So all those mistrust is there, that is the reason why these cases are delayed, because we want to treat all the patients with IVIG, but the convincing is great, it's like 100%. Once on echo there is some change in coronary. That is the main handicap. Once IVIG is as cheap as penicillin, I think lots of children might get it and we might prevent the heart disease at all.
But the problem is that the first change on echo will appear 7 days plus.
Yes.
Dilatation or, the softer signs of echo, most adult cardiologists may not even be able to pick up.
100%, we get patients nowadays, as somebody was pointing out, that pediatricians are going towards that direction. Fever, rash, okay, and platelets especially very high, could be KD, and they get the echo done. And majority of the echo is negative. When they are transferred to DMC, they have large aneurysm. The adult cardiologists have not even heard of the term KD. When I was taking a duty leave to my cardiologist as the HOD, the principal, he said, I am going to attend 5 days KD. He said, what is like KD? Because they don't see KD. They are seeing the consequences of KDs. We are getting very young people having diffuse coronary disease needing bypasses. So we have to make aware adult cardiologists also to be involved in, because it's a pediatric disease.
What I am saying is based on our own experience and unpleasant experience, very, very unpleasant experience. So because Dr. Rakesh had presented a paper at the Yokohama conference, that what is the reason for development of large aneurysms? So we grouped medium-sized and large aneurysms together. We didn't use the term giant aneurysms. And the main reason was delays in diagnosis. So the practice of getting an echo before starting IVIG, I think that has to be reviewed depending on where you are practicing. If you are working at the Institute of Child Health, they will be able to get the echo there and then. But even in many tertiary level hospitals in our country, getting an echo for a child with KD, getting a reliable echo is not there. And that is precisely the reason that in our unit, our echoes are done not by the cardiologists, they are done by these fellows. The echo machine is right in the ward, they don't have to go to the cardiology department. We have done this because of our experience. So these DM fellows, they do the echo and they do it on a daily basis. They sometimes do it twice a day. And every clinic day, they end up doing something like 10 to 15 echoes. Because, and their reports are reasonably accurate. Because we compare them with what Dr. Mansoor shows later on CT. But I again would emphasize that diagnosis of KD does not require a cardiologist. The earlier you do away with a cardiologist, I seek your apologies, Dr. Devdatta, Dr. Amitabh and Dr. Sari. We need your help for assessment of KD, not for diagnosis of KD. Yes, by all means, you need their expertise, their skill. But for diagnosis of KD, we do not need them because it will result in delays. And then what happens is, the parents say that echo is normal, why should I treat? And convincing that parent is virtually impossible because he has more faith in a person who has a higher degree than on a person who is a poor MP. So that is a practical problem that we have.
Out of 20, sorry, I'm taking more time, out of 20, we may be having lots of heart, only one person is trained. Even in our Hero Heart Center, only one person has that eye for coronaries. Rest of them missed, even in DLC. So what I would suggest is a request also, can you start some observership for the pediatricians to train in your center so
That
that...
is exactly why we are doing the same thing. And that is the reason why at the last Kawasaki disease conference at Patna, we had an eco workshop. Okay, so with this we go on to the second talk, which will be taken by Dr. Rakesh Pilania.
Thank you, sir. And thank you, Priyanka, sir, for the giving me a stage after your epidemiology. You have given enough. So I will just focus on what is happening in KD in India actually. So what we have learned is that the global epidemiology of KD, which if you see, there is a paradigm shift in last 3 decades, and the incidence of KD is increasing. And in the developed world, rather I would say now in developing world also, the KD has replaced acute rheumatic fever as the most common cause of acquired heart disease in children. And KD is also now being recognized in 2 most populous countries like India and China. And but what we have problems is like as sir has also highlighted that because the reliable data comes from the Japan and Taiwan and Korea only, because they have a nationwide data. We have only city-based city-specific data in both in China and India and also in other countries. So, but the emergence of KD as the commonest cause of acquired heart disease is now engaging the focus of healthcare administrators throughout the world, because this is the possibly the most common cause of like adult coronary artery disease, like a young adult coronary artery disease in the coming future. So this slide has been shown by Priyanka sir that what we have is that the differences of incidence is that Japan, which reports around its incidence has almost increased from 6 to 7 times from last 3 decades, and what in China and India is we have a city specific data only. So the incidence, the KD reported from India is that before 1990 there are only 3 reports of 3 case were reported in India, and this is the first patient where IVIG was given in Kawasaki disease in India. So this was reported in June 1994, and patient was treated in June 1994 and reported in Indian pediatrics in 1996. These are the first two series which was reported from the Trivandrum, Kerala by Noel Narayanan group, and one case series was reported from our group also. So these are the case series which has been reported in 1997, and these are possibly the first series of the Kawasaki disease cases in India. So, but what is the incidence of Kawasaki disease in India? That we are missing actually. So, like we know the figures of incidence of Kawasaki disease from the 3 well-defined incidence data countries. So, but over the last 3 decades, what we have observed, and I will show you in next 10 minutes, that the incidence because of increased ascertainment or increased awareness of the Kawasaki disease in India, there is incidence has increased. but however there is a paucity of nationwide data. So this is the first time we have attempted how to to calculate the incidence data. That it was done with the help of Professor Jane Burns. She has suggested sir to that whether we can have some incidence data from Chandigarh, because Chandigarh has some peculiarity that this is a union territory and PGI is situated in such a situation that most of the patients, whether they will directly come to our institute or for a second opinion, will come to, but this would be the least incidence data, because basically it is possible that we have missed, or maybe other patient may have went to the other hospitals also. So, but possibly this is the least possible incidence data which is for Chandigarh, and based on this, over the 1994 to 2008, the incidence figure has shown that the incidence has increased, and it started from just 0.5 per 100,000 children. So worldwide we see the incidence of Kawasaki disease is less than 5-year-old children, less than 5 years. But here we, in initial data what we have done is that incidence was calculated up to 15 years, because there were very less patients below 5 years of age, and we have to do for an incidence data of less than 15 years of age. And it is possibly also related that so mean incidence of KD, which was so which age specific incidence, if you will see that incidence data is also more in the children like 6, 7 to 8 years of age, which is contrasting from the Japan and US, because you see the mean age of Kawasaki disease in Japan is around 2 years or 3 years, but we see a mean age of incidence at that time was around 7-8 years, which is contrasting, and possibly that is the reason that we have not seen many patients with less than 5 years, and possibly that is the reason which we are missing these patients. And we have also seen the seasonality in the in peaks in May and October, and there are consistent nadir which we have still seeing in February, and coronary artery abnormalities were documented in 5.8% during that time. Then we have next time we have published from data from 2009 and 2009 to 2014. Dr. Sagar has compiled this data, and again the incidence has increased from the previous, and this incidence data is at less than 5 per 100,000 children, and the incidence has raised ranging from 3.0 to around 9, but the mean incidence in these 5 years were around 5.35 per 100,000 children. So the incidence was gradually rising during these years. And this is a monthly distribution. Again there is a nadir you can see in February, and the peaks are in again May, June and October. So and CAs at this time was documented around 12.9%. So again the incidence of CA, which was Professor Priyankar Pal also highlighted, that we are seeing more coronary artery abnormalities. Possibly it's we'll discuss the reasons behind this also. And the median age at diagnosis was still at 7 years. So which is something which is different from the Western world and like Japan, because again I'm highlighting that possibly we are missing the children less than 5 years, and which is the most common age of the diagnosis of Kawasaki disease. And again male-female ratio suggesting of 3.9:4:1. Then we have compiled the data of 2015 to 2019, which we have recently published, and the incidence figure has again increased to it is almost touching to the 10 per 100,000 children, and which is like similar to the figure which we see in Europe and North America. So North America reports around 15 to 30, while Europe reports around 10 to 20 per 100,000 children. So we are almost touching to that incidence data, but what we see in Japan is almost 40 times of this. So that the current incidence data suggests that Japan reports around more than 400 per 100,000 children. And again monthly distribution suggested that there was a distinct peaks during the May and October, and the nadir was seen again in February. So this is a trend of Kawasaki disease cases at Chandigarh from 1994 to 2022, which has shown that there is an increase in the incidence of new fresh cases at our center, and this you can all observe, and this possibly you have observed everywhere, that during the COVID-19 pandemic we have seen that dip in the, and again it's coming, and recently we have just analyzing our data till 2024, which is showing that incidence data is now in 2024 is almost touching to the pre-pandemic levels. So this is again to highlight that incidence of which has started from just 1.4 to has rose to around 9.72 per 100,000 children. So incidence of KD has increased from 1.4 to 9.72 in last 26 years, and which is almost 10 times of the incidence data which has been when we have started seeing these patients. So this is possibly is multifactorial, as we are discussing, that is possibly due to true increase in incidence which we are seeing in countries which are well versed with the diagnosis of Kawasaki disease also, and more likely an increase ascertainment, because in our setup we have several challenges in diagnosing this disease. So this is a paper we have published recently in Lancet, that incidence of Kawasaki disease among children in Chandigarh. What we have done is that we have then studied the incidence of Kawasaki disease during this period, and we have also done the trend analysis, and to show we have also compared the acute rheumatic fever data, because this is still in a mind of everyone that acute rheumatic fever is the most common cause of acquired heart disease in children, but which is not true, and we have to refute multiple times. As a pediatrician, it's our duty that we should refute this as early as possible, because otherwise too much resources are just allocated to that, and we have to highlight these issues. So what we have done is that linear trend analysis again suggested that the incidence is increasing in Kawasaki disease, and what we have compared the incidence data of acute rheumatic fever as a nationwide data. We don't have a acute rheumatic fever data from. So what we have done is that it's part of a project which is published as part of ICMR's project. The incidence data of acute rheumatic fever we have calculated from there, and what we have shown that the incidence of Kawasaki disease is increasing while rheumatic fever incidence is decreasing. So this is a data from Chandigarh. I have also took data from Penkasar and Jigna regarding the epidemiology of Kawasaki disease at ICH Kolkata. So which is again a hospital-based study, and what this study suggests that from 2009 to 2022, around almost more than 13 years, the Kawasaki disease cases were 229. While in just 2 years, they have seen 54 patients, new patients, and again in next 1 year only, almost 1.5 years, they have seen 80 cases. So the incidence, the true load of the patients is increasing. So this is just a hospital-based data to suggest that case load is increasing and again to suggest that they have also seen the IVIG resistance and coronary artery abnormalities, and what we were discussing is that IVIG resistance, if we can see, is almost 8%, while giant aneurysm figure is almost same, or rather it is decreasing, but the true coronary artery aneurysms are increasing from 21% to 33%, which is a significant figure to note. Again, age distributions to suggest that in patients, it's a more than 5 years group is around 5.6% or 6%, while infantile group is almost 1/3 of the patients in their group. So this is an extremes of the age, because we know that less than 1 year and more than 5 years children may have more chances of developing coronary artery abnormalities, more specifically in infantile age group, and so which suggesting that at this center we can see that almost 1/3 of patients are infantile, and possibly that is one more reasons that we are seeing more coronary artery abnormalities at your center. And incomplete KD figure has also rose from like 20% to 30% over the years. So what we have seen is that this is the available data from India, but good part is that we are able to diagnose these patients, and the centers in India with experience in diagnosis and treatment of KD is increasing. I know that we have to add many more pictures here, but this is possibly related to that because there is increase specialized and expertise, specialty and expertise at the several centers, and because of these availability of these specialists, we are able to diagnose more patients in these regions. And there is an exponential increase in the publication of Kawasaki disease in India, which is like before 2000, you can see now it's in 2023, we have almost 60-70 publications per year in last 2-3 years, which suggests that the awareness and incidence of this disease is increasing. So this is possibly related to the several things, because awareness has increased amongst pediatricians, internists and cardiologists. Diagnosis, there are always concerns of underdiagnosis and overdiagnosis, which the disease which has a clinical diagnosis, and we were discussing that if you wait for echocardiography to diagnose this disease, then you are mistakenly taking this. So again, availability of echocardiography, although it's not ideal, but again there are several improvements. So in next one and a half minute of I will show is that if we are seeing that incidence data is increasing, what are the prediction, analysis and public health perspective of this disease in India? So if we see the global epidemiology trends in the Kawasaki disease, and so what we see in the United States, KD in 1990s were 4.5 per 100,000 children, while in 2020 its incidence data is almost 20. While in Japan you see acute rheumatic fever in 2020s it's more of 90s, in acute rheumatic fever in Japan is almost anecdotes which they don't see. KD in 1990s were 90 per 100,000 children, which is like in 2020 is 350 100,000 children. So the incidence is worldwide increasing, and so Japan with a population of 130 million reports more than 15,000 now. The recent data suggests that this figure has crossed 15,000, and so corollary to this is that 1% of all children born in Japan develops KD before age of 10. So why should we will be different, because we are also having in the same regions Asian descent. So if we extrapolate our KD incidence data of Chandigarh and to our Indian populations based on our calculations, if you see the total population is around 1.4 billion now, and approximate population of children below 15 would be around 426 million. And if we extrapolate the Chandigarh data to Indian population, the estimate number of children will be affected is around more than 20,000. I don't think that we are diagnosing this much of children in India. So, and CA would likely to develop in 25% if you don't treat. So we are accumulating this much of missed Kawasaki disease in India. So at least more than 5,000 children with significant CA due to KD are being added year by year in India. And so what we have done is the prediction analysis based on our trend analysis of incidence data to predict the incidence of Kawasaki disease at Chandigarh over next 5-10 years from 2019 to 2030. So what we have seen that incidence of Kawasaki disease is likely to increase at least up to 2030, and this figure based on this figure we have come to that 1.7% per month incidence case burden is possibly will increase in Chandigarh. So if you project this, because if you see the incidence of Kawasaki disease in Japan is 350, Korea 134, Japan and Taiwan is 84, Shanghai reports almost 107, Hong Kong is 74. So mean Asian KD incidence is around 150. But in Chandigarh we report just around 10. So if we have to take, because the Asian descent, there is a genetic predisposition to this disease, and possibly we have more similarity to the Japanese than the US or Europeans. So based on that, possibly we are missing at least 15 times of, based on these projections, the mean Asian KD incidence, 15 times more cases would be there. So that means that the incidence of Kawasaki disease in India is grossly underestimated. So to conclude, that KD is now the commonest cause of acquired heart disease in children, and which has having overtaken acute rheumatic fever, and the prediction analysis which we have done over 2020 to 2030 indicates a continued rise in KD cases with an estimated monthly rise in around 1.7% in children less than 15 years, and with increasing awareness and increasing diagnosis, we have to improve that what can be done for a better surveillance and better intervention to address this issue. Thank you.
Thank you, Rakesh. This talk is now open for questions.
Is there any particular community prevalence for the KD patients who have in the Chandigarh or India?
So we possibly you are asking regarding the community. So we don't have looked into that perspective and this incidence data is calculated based on that the patients who are resident of Chandigarh and the denominator is the population of the Chandigarh. We see patients from several part of the India, mainly from Himachal, Haryana, Punjab, Chandigarh, and then part of UP and Rajasthan also, and several other patients. But in the incidence data which we have calculated is the patients who are resident of Chandigarh only, Union Territory Chandigarh, not even Mohali and Panchkula also. So that based on that we have calculated the incidence data. Possibly this is an underestimated figure because few patients will be treated in two major government hospital also and few private sector hospitals also. But this is possibly the at least minimum incidence of Kawasaki disease in Chandigarh. Yes, ma'am.
Excellent presentation. I wanted to know was that these are the cases who were based primarily on the criteria?
Yes.
Echo was majority of times normal because you said few had coronary dilatation and all.
So basically, ma'am, you are asking that the diagnosis of Kawasaki disease based on American Heart Association statement, and if I will talk to regarding the coronary artery abnormalities, the coronary artery abnormalities in latest paper is around 17% of the patients has developed coronary artery abnormalities in these patients. So which is if we see from the previous data which we have published in 2000 up to 2008 it was 5.8%, 2009 to 2014 was around 11%, and now it is around 17%. So CA incidence has increased over the time.
And regarding the Z scores and the size of the coronary, is it related to population or are we taking, what is the standard by which we are comparing our scores?
And this is a very important, yes.
So I think we now conclude this session, and I would ask
to chair the next session, we welcome Professor Tapas Kumar Sabui. He is a professor of pediatrics at the Shantiniketan Medical